Thank you for the opportunity to speak with you again. My task this afternoon is to speak with you about infrapopliteal interventions. This is going to be a little bit different from what I think you might have been expecting from a interventional cardiologist. But I think when we talk about infrapopliteal intervention, we need to revisit the issue or the topic of critical limb ischemia, which results from markedly reduced lower limb blood flow, most often involving the infrapopliteal vessels. Atherosclerosis is the most common cause, and it can affect up to 1.5% of the population over the age of 50. You have to remember that the risk of cardiovascular mortality in this patient population is about 3 to 5 times increased. And if you remember some of the data that you've seen earlier, you can see that there's attrition of these patients in follow-up period of time when we try to compare results. Critical limb ischemia is the term used for patients with chronic ischemic rest pain, ulcers, or gangrene attributed to inadequate blood flow or arterial occlusive disease. The manifestations, this is a manifestation of PAD with chronic ischemia, again, rest pain, ulceration, tissue loss. In knowing exactly what we're dealing with when we deal with this patient population, it's not so much just the technical aspects of putting a balloon or a wire or a stent in an artery. It's actually knowing the pathophysiology and the history and the anatomy of what we're dealing with. And certainly when we discuss these patients, we need to be familiar with the Rutherford classification, which quite simply defines the degree of claudication that patients have. And by the same token, the Fontaine stages of claudication, so that we know what we're talking about when we describe these patients. When we describe these patients both orally or in the literature, that we're discussing the same type of patient population. This has not always been the case, and that's part of the reason that some of the information I'm going to present to you is biased and doesn't allow us to make very firm conclusions about what's the best treatment for these patients. For infrapopliteal intervention, the indications are, again, rest pain, non-healing ulcers, and gangrene. So patients that just have claudication are typically not patients that are considered to be candidates for infrapopliteal intervention. And I think when we look at some of the guidelines a little bit later on, that's going to be something that is echoed in that data. However, I would say that there are some patients that are, because of their jobs, are significantly limited with claudication, and that or intervention in their infrapopliteal vessels may not be such a bad thing. We look at limb salvage. What are the treatment options? Distal bypass, endovascular, and question whether or not gene therapy is going to be a durable or viable option for these patients, I think remains to be determined. So the CLI therapy, the revascularization works. Why does it work? Because it improves the blood flow, it relieves the pain, and ultimately it promotes wound healing. If these patients are not revascularized, then they have the risk of gangrene and/or sepsis and death. What increases the risk of limb loss in patients that have CLI? I think these are factors that we need to consider when we look at the comorbidities of our patients and consider patients for one treatment option versus the other. And certainly factors that reduce the microvascular blood flow are well known to you. Those are diabetes, renal failure, heart failure or shock, vasospastic conditions, and cigarette smoking or tobacco use. Factors that increase microvascular blood flow need are things like infection, skin breakdown, and trauma. The objectives of diagnostic evaluation for patients with CLI, I think this again is important and taken from the sort of the task documents and from the ACC/AHA guidelines. The objective is to confirm the diagnosis. We don't want to be fooled that this is something other than atherosclerotic disease in the lower extremity. Localization of the responsible lesions. So patients can have multi-level disease, but we need to identify the lesion that's responsible for them having their CLI, gauge the severity of the stenosis or the disease, assess hemodynamic requirements for successful revascularization. That means is that, we typically think that if we open the more proximal segments, that may be enough hemodynamically to support these patients or for these patients to have wound healing. For patients with CLI, that's not the case, and the traditional teaching is that they will need to have inline flow all the way to the foot, but that inline flow may not be just as simple as opening the only vessel that we see there. It may require more attention to detail. And assess patients for endovascular operative risk, whether or not the patient is a candidate for operative procedure or endovascular therapy is the only treatment option. This slide just simply shows you that this is a patient that has SFA occlusion and has a disease in the infrapopliteal segment. So when you think about the hemodynamic assessment of this patient and what would this patient need to promote wound healing, it's going to be something more complex probably than just simply opening up the SFA. In this study, it was a decade of experience with dorsalis pedis artery bypass. This was an analysis of the outcome in more than 1,000 cases. Why is this important? Because even though it's older literature from 1990 to 2000, they did over 1,000 bypasses to the dorsalis pedis. And within 1 month of surgery, the mortality rate was about 1%. 4.2% of the grafts failed. 13 of those that failed were successfully revised. And when you look at sort of primary and secondary patency in this patient population group, you can see that this does tend to be a durable procedure. And part of the attrition that you see here is that some of these patients actually died during the period of follow-up. The dorsalis pedis bypass was safe in this institution. It was simple and durable, and remains the mainstay of treatment for ischemic feet, especially in diabetic patients. Now, why is this important? Because when we look at randomized data, in one of the randomized trials, or probably one of the few randomized trials that compared similar groups of patients with critical limb ischemia or infrapopliteal disease, the PREVENT 3 trial provided some outcomes for surgical bypass, again in a randomized fashion, and survival and limb salvage rates were comparable to the observational reviews. So the previous study that I showed you, although observational with good results, this randomized trial echoed those results. And so despite the limitations in the surgical data, and the limitations are which vessels were involved, what types of techniques were involved, there are a lot of differences between the patient populations that get treated. Despite that, this surgical data that we have is really the best we have, and that's sort of the gold standard or the benchmark against which any infrapopliteal intervention is being measured. So everything that we do now is still being compared to these older studies with, if you look at them, actually very good surgical results. Now, percutaneous revascularization has been reported since the early 1990s. It's increasing in use and increasing in success with advances in technology and expertise. Debulking devices, and I put this in, probably could have said this at the end, but I think it's important for you to understand that all of these other devices have not really proven to be anything better or more durable than balloon angioplasty or primary stenting. PTA of infrapopliteal arteries, again, older literature from 1999 to 2007. In this group, 1,400 limbs. Stents were only used in 93 of the arteries. So they preferred, and why I present this data is they preferred to use balloon angioplasty alone, irrespective of what the length of the segment was. And in their later part of their sort of registry data, they started using some self-expanding stents for suboptimal balloon results. Their overall technical success was about 90%, and they concluded that the clinical outcome favorably affected by a higher number of successfully treated arteries. What does that mean? It means that here, even though they did balloon angioplasty on a very large number of patients, and even though the traditional teaching was that you needed inline flow or you only needed one vessel flow to your foot for a favorable outcome, these investigators concluded that the more vessels were treated, even with simple balloon angioplasty, the better the short-term and long-term results. If we look at another study, here is infrapopliteal angioplasty, and it's titled Relation to the Transatlantic Intersociety Consensus. And this one is important because it stratified the patients by their task class, they had 93% technical success. And they noted that task D, or the most severe form of atherosclerotic lesions, was associated with decreased technical success. But despite that, angioplasty was reasonable for patients with CLI, even though they may have had restenosis, even though they may have had occlusion at some time in the future, they still had limb salvage and they still had wound healing. Infrapopliteal stents, there are a lot of case reports and registry data with bare metal stents in the infrapopliteal segment. And in my institution, we've been doing this since the early 1990s. They're now self-expanding stents. The balloon expandable stents, as you heard earlier, run the risk of deformation and being crushed. And we're limited by the sizes, and that includes the length and diameters of the available stents that are on the market at the present time. Drug-eluting stents, in theory, because of the results that we've seen with drug-eluting stents in the coronary circulation, coronary arteries are very similar in size to arteries in the infrapopliteal region. It's sort of intuitive that you would imagine that the drug-eluting stents in the periphery or in the infrapopliteal arteries would have the same benefit that's been derived in the coronary circulation, i.e. less restenosis. Again, it's limited data, and we're limited by the size and potential deformation of the balloon expandable stents, which, at the present are the only drug-eluting stents that we have available to us in the U.S. And certainly any of you that have used drug-eluting stents in the infrapopliteal area realize that you need a lot of stents because these lesions are usually very long, and so we're overlapping stents. And anytime you're using more than one stent, you significantly increase the cost of the procedure. There's some registry studies of drug-eluting stents for below-the-knee CLI, and I just put this table in simply to show you that there are a large number of registries, a significant number of limbs that have been treated. The number of stents, if you just simply look at the number of limbs that's treated, 765, and then the number of stents, you can see that these patients, for the most part, are receiving more than one stent per patient. And then there are randomized trials for below-the-knee drug-eluting stents. You can also see on the first one the Achilles or the Cypher stent, which is no longer available. And the number of patients, again, small number of patients. Lesion lengths, I think, are similar to what's been published in the literature, meaning over 10 millimeters in length, or over 10 centimeters, in length. And the binary restenosis rates have been favorable with this technology. So at least we have some indication that maybe drug-eluting stents for infrapopliteal disease may be a durable alternative. Now, not only drug-eluting stents, how about drug-eluting balloons for infrapopliteal vessels? This study that's just been published this year, 104 patients, 109 limbs, lesion length, again, 176 plus or minus 88 millimeters, with 3-month angiographic follow-up in part of the patient's 84 arteries. Restenosis was 27.4%. That restenosis was usually focal and amenable to a secondary treatment. Limb salvage was 95.6%. So very good limb salvage. Restenosis rates lower than what had been published previously with balloon or with plain balloon angioplasty. So again, something that's looking favorable for this technology maybe being durable or an alternative to treat patients in the future, and potentially treating patients for infrapopliteal disease and treating more than one vessel at the same time, as opposed to putting multiple stents below the knee. This would be a technology that certainly I think would be applicable to below-the-knee interventions by being able to use the drug-eluting balloon in multiple segments in the same patient. So we've gone from sort of the knee down, now we're down to the ankle, okay? So this is sort of a cohort of patients from Dr. Kawahara from Japan who published a sort of interesting report on stent-assisted below the ankle angioplasty for limb salvage. So you're probably all thinking that if you put a stent below the ankle, then it obviously has to be deformed or something has to happen to that stent. It was a retrospective single-center study. They had 40 CLI limbs or patients in their study. Their technical success was 93%. So these are good operators, 37 limbs, 3 that they failed to cross, an acute or subacute occlusion in 9 limbs. Some representative panels from one of their cases. You can see the balloon in the left-hand panel across the ankle, and the result with flow to the foot in the plantar arch on the right-hand panel. 8 of their patients had stenting to their dorsalis pedis. You can see the 6, 12, and 24-month results here with limb salvage above 90%, even out to 12 months. Patient survival only 77%. Again, this is a very sick cohort or population of patients, so these patients, by virtue of having critical limb ischemia, are more or less marked for premature death. Freedom from repeat revascularization or intervention, again, was only about 40%. And interestingly, they had acute or subacute thrombosis in 2 patients. Of note in this study, too, the clinical outcomes were satisfactory. The need for repeat intervention was high. The further technology to avoid the deformation that occurred. Okay, so these were balloon expandable stents placed at the level of the ankle or below the ankle. They did have deformation, and on follow-up angiography, even if the stent was completely occluded, it obviously had remained patent long enough for the patient to have wound healing or relief of their symptoms. So even with occluded vessels and a crushed stent in the ankle, patients still had relief of symptoms, oddly enough. These last few slides show the sort of the task 2B, because the other study that I showed you when I talked to you about, it was based on results of task. Well, that was the first task. This is task 2B, and in task 2B, I encourage you to just look at that on the internet, but just to go through this very quickly, this is the task A. The shaded areas are sort of background, and the one that's not shaded is the area that's going to get treated. Task B for the infrapopliteal area. Task C, becoming more complex, and task D with basically all of the infrapopliteal vessels occluded with long segments of occlusion. Just a representative panel of tibial stenting, and even with distal bypasses, they can be stented. Now, was mentioned earlier, when you do these procedures, and that's why I haven't given you a lot as far as the technical parts of it and whatever, you need to know all of this literature, you need to know all the background and the durability of what you're planning or contemplating on doing for these patients. You also need to have the equipment, obviously the balloons, the stents, whatever on your shelf, but you also need a cath lab that's will help you to perform these procedures. This is just one of our cath labs, and you can see over on the right side with the large red oval is the 14-inch II. The smaller II that we use for coronary interventions and procedures is over the patient's table. This larger II can come in, the smaller one gets out of the way so that we can use the large one for peripheral interventions. And then we have what's called the slave monitor in the purple circle, which is a monitor that can move to either side of the table from head to toe to allow us to be able to visualize when you're working sometimes from an antegrade or a retrograde or in awkward fashions, which is typically what happens when you perform these more complicated procedures. If you read the task 2B document, I think it's important to understand some of the conclusions that were made. So they made new recommendations as far as the other vascular beds, but when it got to the knee or the infrapopliteal area, it became very vague. And some of the things that they weren't as vague on are the things that I think are most important. And when they talk about the role of endovascular revascularization, its primary mode of therapy, there's a presumption that the interventionalist, it doesn't matter who you are or what your specialty is is a technical expert to perform these procedures. They also say that you must have all the devices and technology, as we mentioned, the laboratory, the equipment on the shelf. And you must be able to explore the strategies that's going to give you the best result and going to be the most cost-effective and the most durable. And then a fundamental caveat is that only experienced operators capable of efficient management of potential complications should employ these techniques. So not only do you have to have the equipment, not only do you have to have the medical knowledge, not only do you have to have the technical skills, you also need to be able to manage the complications, which sooner or later you will have complications, and you need to know how to manage those complications too. And if you don't have all of those together, then this is probably not something that you should be doing. As was mentioned earlier, this is something that's not sort of not beginner type of a procedure. In conclusion, infrapopliteal intervention is increasingly being used to treat CLI or infrapopliteal disease. Technical success, freedom from restenosis, reintervention, or amputation should increase with newer technologies and appropriate case selection. This is a representative case from my institution, a man who has peripheral neuropathy but also had claudication and rest pain. It's a very difficult history to sort of decipher what was the real culprit for him. And this was his angiogram of his right leg. Here you can see contrast still showing up at his ankle. And one of them is not showing. And basically what we do is with the contrast, under fluoroscopy, seeing this contrast with a micropuncture set, stick or needle stick this artery, work in a retrograde fashion. So we have an antegrade access to perform the angiogram, and a retrograde access you can see at about 7 o'clock, the wire coming up in a retrograde fashion. The retrograde wire is passed into a collateral or to the remnants of the perineal artery, and the antegrade wire is then able to cross the total occlusion. Then the wire that's coming retrograde is snared, and so the procedure can be completed from the femoral route without having to put larger devices or larger catheters in through the pedal approach. Then angioplasty is performed, and then stenting, and then the final result with flow in line all the way to his foot. Thank you very much.